Hi, this is Ian Bodrick,
And Liang Wu.
and welcome to the Clinical Correlation.
For our first case, we have no pain, no gain.
So this is an interesting case for us. Liang was the provider taking care of the patient in the ED, and I helped care for the patient in the ICU.
This is a 65-year-old male with a history of diabetes and hypertension. He was brought in by EMS during a morning shift. The chest pain began the previous evening. It was a left-sided pressure sensation that radiated to his left arm.
So that sounds like a pretty good story for ACS, Liang.
Definitely so. EMS obtained a 12-lead EKG with some concerning findings, and he was given aspirin and sublingual nitro en route. This is the EKG that was handed to me by the paramedics. There are some very subtle changes. There are ST elevations in V1 through V3. However, these are only around 1 millimeter each.
There are also some reciprocal changes in 2 and AVF. So I guess I need to ask, did you activate the cath lab?
So, good question. To answer that, we need to define ST elevation MI. So for a technical definition, we need to refer to the Third Universal Definition of Myocardial Infarction. This was written by some very important people from these important organizations as listed. ST elevation MI, by definition, must have new ST elevations relative to the TP segment in 2 contiguous leads with reciprocal changes.
But does the degree of ST elevation matter?
So it does. In women, the ST elevations in V2 and V3 must be at least 1.5 millimeters and 1 millimeter in any other leads. In men greater than 40 years of age, this needs to be 2 millimeters in V2 and V3. And in men less than 40 years of age, this increases to 2.5 millimeters.
So this patient's EKG provided by EMS did not qualify for a STEMI, correct?
It did not, but it was still concerning. So an EKG was repeated once the patient was roomed in the ED.
And at this time, if I remember correctly, his chest pain had improved as well.
That's correct, it had. But you will see that on this EKG, it's still pretty concerning. There's still that 1 millimeter elevation in V1 through V3, but now the patient has very pronounced T waves as well, especially in V2, V3, but also V4.
Well, still technically not a STEMI though, but I'd agree it's concerning with all the diffuse T-wave abnormalities. Maybe he's always had an abnormal EKG.
So that's definitely true. Fortunately, this patient had a previous EKG. So let's compare this one to the abnormal one we see now.
And yeah, I'd definitely say that's different than before.
So let's take a look again back as EKG on this visit.
So I say this looks pretty Wellens-like.
So you're referring to the biphasic T waves in V2 through V3, and that's definitely true. So what is Wellens syndrome? It's characterized by deeply inverted or biphasic T waves in V2 and V3 with isoelectric or minimally elevated ST segments. That is less than 1 millimeter.
And interestingly, these patients can have zero chest pain at the time their EKG is taken.
So why does this matter? These findings are highly specific for a critical stenosis of the left anterior descending artery, which can be devastating. These patients generally have poor outcomes and require invasive therapies. 2 T-wave morphologies are seen in Wellens syndrome. Type A is characterized by very deeply inverted T waves as seen here, while type B is characterized by biphasic T waves. Though V2 and V3 are the typical leads in which these changes are made, in some patients these T-wave morphologies can be seen in V1 through V6. But what exactly is happening with a T-wave?
So when a patient has a sudden occlusion of the LAD, they're going to have chest pain. This causes a transient anterior STEMI with reperfusion, whether it's spontaneous or whether we've given them aspirin. The pain resolves and the ST elevation improves, transitioning to biphasic then deeply inverted T waves. This morphology can also be seen in patients after a successful PCI. However, the coronary reperfusion in Wellens syndrome is unstable.
So that means that the LAD can reocclude at any time. Patients with Wellens are at risk for extensive anterior wall MI within the next few days to weeks. Additionally, if inappropriately stress tested, these patients can actually have a cardiac arrest or suffer an MI during the testing.
So despite the specificity of these findings, it's important to also keep a broad differential for other causes of abnormal T waves. The patient was taken emergently to the cath lab and underwent PCI. His troponin on presentation later returned at 0.57, and a repeat troponin after PCI was 4.68. In the ICU, the patient was given dual platelet therapy and started on cardiac rehabilitation. So all things considered, he did well. When I saw him up in the ICU, he was actually running laps around the ward. He was discharged home on hospital day 5.
The echocardiogram performed on hospital day 2 showed normal chamber size, but severely reduced left ventricular systolic function, with an ejection fraction of 29%. There was akinesis of the septum, apex, and inferior wall, and impaired LV relaxation. There were no prior echocardiograms for comparison. Only time will tell if any of this is due to cardiac stunning or permanent ischemic changes. And obviously, this echo that we're showing you here is that of a normal heart.
On cath, the patient had total or partial occlusions of the LAD, circumflex, first and second obtuse marginal, and RCA. He received stenting of the second obtuse marginal, LAD, left circumflex, and the left main coronary arteries with drug-eluting stents. Additionally, the RCA was subtotally occluded but not treated at that time.
So in summary, pay attention to your T waves on EKG. Always compare to a prior if available, and if uncertain, always get serial EKGs.
And be aware that with Wellens syndrome, patients can be pain-free. However, with critical LAD lesions, these patients are high risk for morbidity and mortality.
So that's our first case. Thanks for listening.
So send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com. You can also follow me on Twitter @MDNotified.
Have a great day.